Just to introduce Dr. Lipika, although I'm sure everybody amongst you know her because she's the most popular of our faculty members. She's a senior consultant in fertility, sexual medicine, and PCOS, and she clinic by the name of Arogya Clinics and Origin Fertility Care. During her MBBS, she was the best graduate and state topper, and during her MD, she got the gold medal award, and which is by no means a joke. Such accomplished academic career. She did a fellowship in reproductive medicine, clinical embryology, and ultrasound in subfertility and PCOS. She has a diploma in sexual health and subfertility. She is a leading member with ISAR and as the Odisha Managing Committee member as well as ISAR Young Brigade. She is a member from 2024 to 2026. She is a member at PCOS Society. She's a member of ISAR's SIG Sexual Medicine, and she is the East Zone Coordinator of Foxy Young Talent Promotion Committee. And she has got numerous accolades to her, and it's very difficult to enumerate every detail about her. She's the convener of National ISAR Gurukul program. She is a very commonly invited faculty at various national and international conferences, and she has a special interest in PCOS, reproductive genetics, male fertility, sexual health, and reproductive immunology. And she is also an editor as a national in a national IVF newsletter. She's a life member of Foxy, ISAR, ICUOG, IFS, PCOS Society of India, and Fertility Preservation Society of India as well. So these are few words for a very bright young consultant, and it's very difficult to describe her in these few words. So, to you, Dr. Lipika, I'm sure you're going to have conduct a wonderful lecture, and many people are looking forward to listening to you. Over to you.
Thank you so much, sir. So I welcome you again, once again, to this demo class. After this, you'll be having another demo class 2 days later by sir. So this will be I think the class on 23rd will be the last class prior to the commencement of the course. So today we'll be discussing about ovarian hyperstimulation syndrome. Although a lot is talked about OHSS free clinics and like we are still, encountering so many cases. I think in my short clinical experience of 5 to 7 years in IVF, I have seen around 10 to 15 cases of OHSS, which is still a huge number. And I think discussing OHSS is very important for all of us to have an idea about that. The worst thing probably about this is it is like unpredictable. It is predictable in most of the cases, but like the predictability is difficult it can happen suddenly in the least expected cases as well. Therefore, you should be aware. And I'll let you know why the predictability is difficult also in few cases. So we'll start with the session. The details will be taken up further again in the course. The same session will be there, but this is you have to be attentive throughout this lecture as well, and we'll share the recording with you. Okay, so these will be the outlines of today's talk. I hope my voice is clear. Sir, is it loud and clear?
Very nice. It's very clear. The screen is also nicely visible.
Okay, so these
And
will be the outlines of today's session on OHSS. You can interrupt me anywhere you feel like. You can raise hand or you can put your questions at the end of the session. All right. So
you can also put in your queries in the chat box. We can
yeah,
take
you can
the
put it in the
questions.
chat box as well. Either sir or I'll approach the doubts. So, like ovarian hyperstimulation syndrome is an exaggerated response to ovarian stimulation therapy. OHSS is typically associated with exogenous gonadotrophin stimulation and rarely observed with other agents like ovulation inducing drugs like clomiphene and letrozole. It is very, very rare. However, it is common with exogenous gonadotrophin stimulation in controlled ovarian hyperstimulation of IVF ICSI cycles. Clinicians who prescribe ovulation inducing agents must be prepared to recognize and manage OHSS. It is usually a self-limiting disorder that resolves spontaneously within several days but may persist for longer periods, particularly in conception cycles. So in case the lady conceives after a frozen embryo transfer, there is more likelihood of the syndrome becoming more severe and persisting to a longer period. But if she doesn't conceive, it will come down and it resolutes itself within few days. The syndrome has a broad spectrum of clinical manifestations from mild illness needing only observation and monitoring of vitals and other parameters to severe disease requiring hospitalization and intensive care therapy. The syndrome is characterized by ovarian enlargement due to multiple ovarian cysts and acute fluid shift into the extravascular space. So let me tell you something about the details of intra and extravascular space, which is very, very important for understanding the manifestation of these syndrome. What happens is you have a vascular component which is inside of the blood vessel, and you have an extravascular component which is called the third space. So it includes all your peritoneal space, pericardial space, pleural space, all of it is the third space. So when the fluid from the intravascular or the vascular component shifts to the extravascular component due to any reason, predominantly because of increase of capillary leakage, what happens is the space between the endothelial cells have tight junctions, and therefore there is normally no leakage of intravascular fluid to the extravascular component. But because of the loosening of the endothelial cells and damaging of the endothelial tight junctions, fluid can leak into the third space, which is called the extravascular space, and that is reason for manifestation of the variety of symptoms of ovarian hyperstimulation syndrome. Therefore, this syndrome was earlier called capillary leakage syndrome. So because the intravascular component fluid leaked into the extravascular or the third space, therefore this was called the capillary leakage syndrome. Now, what are the complications of this syndrome? It can include ascites. As a result of leakage of intravascular fluid to the extravascular component, there will be concentration of blood cells within the blood vessel, which is called hemoconcentration. So the blood will become more thick and viscous, and therefore that is called hemoconcentration. Hypovolemia happens because of the leakage of the fluid to the third space, and obviously because of loss of fluid, there will be electrolyte imbalance. Understanding pathophysiology and symptoms of this syndrome will actually help you and guide you in managing the syndrome better. So from here you can understand that for these patients you need to replenish fluids. That is number one. The second thing is you need to maintain the electrolyte balance. Otherwise, she will have consequences of hyponatremia, hypocalcemia, all of that. Because of the prevalence of therapy employing ART is increasing, so we know that a number of IVF cycles and ICSI is greatly increasing globally. Therefore, we have to be cautious of predicting and managing this fatal syndrome early. All physicians dealing with females of reproductive age should be familiar with OHSS, as it causes multi-organ dysfunction which may be life-threatening. So mostly OHSS is expected and predictable. However, at times it can be fatal and unexpected. So I'll tell you both the aspects. In which type of patients, when you go for controlled ovarian stimulation IVF cycles, where can you think that she might land up in OHSS, and certain cases which are absolutely unpredictable, because you know every biological body is different. So the response to the same gonadotrophin doses may be varied in different females, although they have the same age, same BMI, but the response to gonadotrophin stimulation can be sometimes unpredictable. So this is the right side upper figure is a ultrasound image showing ovarian hyperstimulation on the ultrasound, and the lower figure shows hormonal medications, and that consequently leads on to ovarian hyperstimulation if not properly monitored. This is again a 3D figure which shows the ovaries which are hyperstimulated, the upper left figure. The upper right figure is again a hyperstimulation syndrome figure wherein the pickup has been done, but still there are some refilled follicles in both the ovaries. The ovaries are being seen floating in the POD, and there is like moderate to severe amount of fluid in the POD as well. Along with, if you do a trans-abdominal scan also, you will see fluid in the hepatorenal pouch of Morrison. You see a lot of fluid in all the dependent spaces of the abdomen as well. You can see the uterus floating here and the ovaries as well, with lot of fluid in the POD. So with natural ovulation, there is one egg forming. With controlled stimulation, you have adequate numbers or expected numbers of follicle forming. But with ovarian hyperstimulations, the ovaries are enlarged, bulky, with unexpectedly high number of follicles forming in the ovaries. Now, what is the epidemiology? So the rate of occurrence has been estimated as follows. We are lucky enough to say that most of the ovarian hyperstimulation syndrome cases are mild, which can be managed in the OPD with investigations and monitoring or observation. Few are moderate, and very rare cases come to severe or critical category of OHSS. So the frequency of OHSS may increase if ovaries are overstimulated with high amount of E2 being released from multiple follicles. So with high estradiol, there is high level of VEGF as well. So which is the predominant molecule that is the culprit of ovarian hyperstimulation syndrome? It is vascular endothelial growth factor. There are a lot of other factors which are responsible, but if you even think of one most important factor, it is VEGF, which increases the vascular permeability and leakage of fluid into third space, significantly resulting in manifestations of this syndrome. Now, the protocols which combine GnRH agonists and gonadotrophins compared to gonadotrophin alone to induce ovulation or stimulation cycles can also increase the incidence of OHSS, because we know GnRH analogs will have a flare effect for a short period, and that can also result in stimulation of more number of follicles than we had expected. So only women with childbearing age are affected by OHSS. This is obvious because with increasing age and when the woman goes beyond reproductive age, the number of baseline follicles in the ovaries will come down. Now, what is the pathophysiology of this syndrome? The hallmark of OHSS is increase in capillary permeability, resulting in fluid shift from the intravascular space to the third space compartment. This occurs predominantly due to HCG injection. So this is very, very important. If one of the injections which is responsible for causing OHSS, it is human chorionic gonadotrophin, which we use as trigger. Okay, later on you will understand what is early OHSS, what is late OHSS, what is exogenous HCG, and what is endogenous HCG. Now we know exogenous HCGs are given as triggers for inducing ovulation or prior to pickup, and what is endogenous HCG, that is released in women who become pregnant after the embryo transfer. Now, what are the factors implicated in the process of hyperstimulation? Increased secretion or exudation of protein-rich fluid from enlarged ovaries or peritoneal surfaces. So one is, I've already mentioned several times, there is increase in capillary permeability of blood vessels and leakage of intravascular fluid to the extravascular component. That is one. The second is, with hyperstimulated ovaries having much more than expected number of follicles, there is also fluid exudation, that is called transudate actually. The fluid through the ovarian peritoneal surfaces can leak into the third space compartment just because the ovaries are hyperstimulated and have multiple number of follicles, more than that is expected. The second is increased follicular fluid levels of prorenin and renin, which causes again leakage of space. Renin and prorenin will cause vascular contraction, which will consequently cause leakage or pressurized fluid to come from the vascular component to the third space. The third is angiotensin mediated changes in the capillary permeability. So we all have heard of RAS system in MBBS days, renin, angiotensin, aldosterone system, right? So with renin, we know they are vasopressors. They increase the vascular contractility and that will cause leakage of fluid into the third space. Angiotensin also causes increase in capillary permeability. That also causes increase of leakage of fluid to the third space, right? Vascular endothelial growth factor or VEGF, you will hear about this molecule several times during this lecture. So this is probably the main molecule through which hyperstimulation happens. It is the major mediator due to the following evidences. VEGF, so why do we allot VEGF as the reason for all of the hyperstimulation? Because VEGF serum levels increase with HCG injection, and often the serum levels of VEGF will correlate with the severity of OHSS, right? The expression of VEGF and VEGF receptor 2 mRNA, which is responsible for formation of those receptors, increases significantly in response to HCG injection, and the peak levels of VEGF will coincide with maximum vascular permeability. Then the third reason, which actually confirms that this is the main culprit behind OHSS, is recombinant VEGF produces effects similar to that of OHSS, which can be reversed with specific anti-serum of VEGF. So in laboratories, it has been seen that if recombinant VEGF is used in the capillaries in the laboratory, there is significant increase of vascular permeability and the manifestations are similar to those observed in OHSS. Prostaglandins, what are the other molecules which are responsible for hyperstimulation? They are prostaglandins, inhibin, renin, angiotensin, aldosterone system, and other inflammatory molecules have been implicated in the etiology of OHSS. Now, I will just, I missed out on explaining this figure on the right side in the previous slide. So have a look at this figure on the right side. This is ovarian, this is a hyperstimulated ovary. What happens is there is release of vasoactive factors. Vasoactive factors are all types of prostaglandins, VEGF, inflammatory markers that causes increase in capillary permeability. So this is a blood vessel where you can see the space between the vascular endothelial cell increases and there is increase in capillary permeability resulting in leakage of fluid to the third space. So because of leakage of fluid to the third space, there is tissue edema, that is ascites in the abdomen, hydrothorax in the pleural space, and because of leakage of fluid to the third space, you have a tightness in the abdomen and chest. Abdomen, chest, and around the heart as well. That is called compartment syndrome. So the patient feels like somebody is stranding her. Okay, she's being compressed by something because of accumulation of fluid in the third space. Now, because of leakage of fluid in the third space, there is also intravascular hypovolemia. So the fluid shifts from the vascular component to the extravascular space that causes hypovolemia, and because of reduction in intravascular volume, there is diminished organ perfusion and consequently renal and hepatic impairment. So because of decrease of blood supply to the vital organs, there is hepatic and renal impairment of function, and inside the blood vessel what happens? There is hemoconcentration, there is loss of fluid, therefore there is hypercoagulity of blood. So you find there is accumulation of platelet plugs here and there, and that results in thromboembolism. Okay, the similar figure here on the right side as well. So you see there are gonadotrophin injections. You can see there are gonadotrophin injections. Then there is high estradiol level from the multiple follicles in the hyperstimulated ovaries. Then you give, prior to oocyte pickup, you give a HCG trigger. What happens? There is more of vascular endothelial factors, increased angiogenesis, and because of multiple corpus lutea formed, because of the multiple follicles that you have picked up. What happens after ovum pickup? The follicles become corpora lutea and they again release lot of vasoactive factors. So we had mentioned VEGF. What are the other inflammatory interleukins? They can be 6, 8, etc. All of which increase capillary permeability, resulting in tissue edema, hypovolemia, increased intra-abdominal, intracardiac and intrapleural pressure, and the consequent effects which I have explained in the previous figure as well. Right? So this is the basic understanding of pathophysiology. This is again very, very important. This slide actually summarizes the entire pathophysiology of hyperstimulation syndrome. You can see with gonadotrophins and exogenous. So I was talking about exogenous and endogenous HCG. So the exogenous one is the trigger HCG which we are giving. The endogenous one is from the pregnancy, all right, from the placenta and from the corpora lutea. In case she becomes pregnant, you get endogenous HCG as well. Therefore, this exogenous HCG is responsible for early hyperstimulation syndrome, and the endogenous HCG adds on to the late hyperstimulation syndrome. We'll go into the details of that. So with HCG injection, what happens? There is a lot of vasoactive or increasing substances which increase the capillary permeability. This is the blood vessel, and the consequent effects of increasing capillary permeability and loss of fluid into the third space. Now, why these two parts are circulated? I've already told you most of the cases of hyperstimulation are predictable. However, few cases still remain to be unexpected, which is very, very fatal. You can be, the clinician cannot diagnose it early because it was not expected. You are late in diagnosis till she presents to you, and then the consequences can be fatal and life-threatening. Because just remember, why does it happen in some patients where you didn't expect? Because the VEGF secretion per follicle of the ovary has a genetic predisposition. So some patients have a genetic likelihood of secreting more VEGF compared to other patients. That obviously you cannot predict from the predicting criteria of OHSS, right? So this is one reason. And the other reason is that there are mutated VEGF receptors in certain patients' capillaries. So what happened? The sensitivity of VEGF to those patients with mutated VEGF receptor 2 is increased. You know, the bondage and the binding of the VEGF to those receptors is very strong. So it does not dislodge itself and remain stuck to the receptor for a longer time. And therefore, the effect of VEGF on increasing capillary permeability also stays for a very long time, perpetuating symptoms of ovarian hyperstimulation. Okay. Now, what are the essential triple coexisting factors, which is the triad of OHSS? It is overstimulation. So you have to predict and decide what dose you have to start a patient on stimulation. That is very, very important. Madam has a lecture on that. I think the first session is on how to decide which type of gonadotrophins and what is the dose you are expected to give to a patient when you start her on a IVF cycle. Okay. So if you do not give a correct dose and if you give her an overdose of gonadotrophins, she can land up in OHSS. So the first loop of the triad is overstimulation. The second is over response. So this is also predictable. In some patients, it is not predictable as well. Oh, all right. So people who are doing IVF will agree. Sometimes you don't expect so much of follicles to grow, but they grow up when you scan her on the 6th or 7th day of after starting injections. And the third and the final very, very important point of the triad is human chorionic gonadotrophin. So remember the three triads of the coexisting links of OHSS, predicting OHSS, overstimulation, over response, and HCG. Okay. Now, if we put things in a table manner, so what are the risk factors? There can be primary risk factors and secondary risk factors. So the primary risk factors are basically patient related. When from the patient, you can think that she might have hyperstimulation. So these are patients where you can predict that hyperstimulation can happen. Who are those patients? A patient with high basal AMH. Which is this group of patient? Usually PCOS patients. So we know a major chunk of patients undergoing IVF ICSI cycles are PCO patients who find it very difficult to conceive spontaneously or with IUI cycles. So number one predicting risk is high basal AMH. Number two is young age. So remember, if you have a patient of 24 undergoing IVF cycle, if you have a patient of 37 undergoing IVF cycle, you will have higher chance of having OHSS in the 24 age female compared to the 37. One reason is young age has higher predisposition. Second is you have a lower number of antral follicles in 37 compared to that in 24. Then previous OHSS history. This is also very important. Sometimes what happen, a patient has earlier cycles of IVF stimulation with OHSS happen to her. So in her, you have to be very cautious when you start the gonadotrophin doses. And PCO like ovaries on baseline scan. If you see that the baseline ovaries already have a higher number of antral follicles, so that will also decide if she can land up in OHSS. All right. There is no particular biochemical marker value or cutoff. However, if she has a AMH of more than 4, I would say, which is in the PCO group, age less than 30, 32 is taken as cutoff, we can take 30. More than 24 antral follicles in both ovaries combined. What is the both ovaries combined antral follicle called? It is AFC, which is analyzed on the baseline scan when before you start the cycle, or you have more number of follicles on the 6th or 7th day of ultrasound. You have more than 14 to 15 follicles which are more than 10 to 11 mm in diameter, or greater than 11 follicles more than equal to 10 mm in diameter. So any of these criteria can also predict a hyperstimulation risk after pickup. According to Martin, if the pre-HCG treatment E2 value, if you do a E2 value, I think most of us do. So if you do a pre-trigger on the day of trigger, you do a morning E2 estradiol level and that is more than 6,000, or there are more than 30 follicles present on the day of trigger, that indicates a chance of severe OHSS, and the ratio can go up to, like the likelihood can go up to 80%. Now, what are the secondary risk factors, which is ovarian response related? So those are the baseline risk factors, which are the primary risk factors. You again have secondary risk factors, which are ovarian risk factors, which are ovarian response related. Okay. So that you can find only on the day of the HCG trigger. High number of medium to large follicles, high or rapidly rising E2 levels, or high number of follicles, number of oocytes retrieved, that will also determine how much likelihood you have of having OHSS. Raised VEGF level. Obviously, we don't do this VEGF level, but for research purposes, it is done in some centers for a few cases. Elevated inhibin B levels, HCG administration for luteal phase support. Remember, in cases where you expect a luteal phase defect, like with agonist triggers, if you're going for fresh transfer, some people use HCG injection administration at a low dose, 1500 IU for luteal phase support. So there is high chance of having ovarian hyperstimulation in those patients. And in case she becomes pregnant after embryo transfer, that is again that will again increase the incidence of having OHSS, which is a late OHSS once she becomes pregnant. All right. So the cutoff values I've already mentioned, more than 5,000. Some books say more than 6,000 as well. More than 11 follicles greater than equal to 10 to 12 mm. Elevated levels on the day 5 of stimulation at oocyte retrieval and 3 days before. So when we start stimulation for a patient, you obviously scan her on 6th or 7th day of stimulation to see how the response has been with the gonadotrophins. So in those cases, if you see higher number of medium or high, like large follicles, that is also predictive of, having OHSS in the patient.
Dr. Lipika?
Lesser age, less than 35, if she has a previous pregnancy with OHSS, polycystic ovarian syndrome, twin pregnancy, because we know endogenous HCG levels will determine the likelihood of OHSS. So if she has multiple gestation, obviously the endogenous HCG levels will be high and low BMI. So lower BMI patients have high risk of having OHSS. Now we'll move on to classifications. Any doubts till now? You can ask me.
Dr. Lipika, can you just go over the last two slides because your voice was a little, I mean, we
All
lost you
right.
for a while, yeah. So last two
Okay, sir.
slides, can you explain again? Yeah.
This one?
The last two slides, the figure and the, yeah, this one, yeah.
Yes, sir. Yes, sir. This is the just a summary of like this one. See, there are two categories of risk factors of OHSS. One is the primary risk factor, which is predictable. And when the patient comes to you, you can see that she is young in age, she has a high AMH, she has high antral follicle count, and she has a previous history of OHSS. So this category of patients are at higher risk for having OHSS. So you have to be very careful when you start gonadotropin injection in this group of patients. Now, as far as cutoff levels of AMH is concerned, we take it as 4. For age, we take the cutoff as 32. Some books say 35 as well. More than 24 antral follicle count. So in both the ovaries, see, when you count antral follicles for individual ovaries, they are called antral follicles. When you combine the antral follicle count for both the ovaries, it is called AFC, or baseline antral follicle count. If it is more than 24 at the baseline scan, she is at higher risk for having OHSS, and high number of large to medium size follicles on the 6th or 7th day of stimulation when you scan her. So these patients are at higher risk of having OHSS of various grades. Now, what are the secondary risk factor? So why this is called secondary? Because after you start stimulating her, you come across these findings. So this is ovarian response related. How her ovaries have responded. According to that, you can predict OHSS midway of starting stimulation. So one is higher number of medium to large follicles, high or rapidly rising E2 levels. See, in some centers, in between the stimulation, E2 levels are done. Okay, I don't do it routinely. It's not done actually, but few centers I've heard in conferences they do. So if E2 levels are being done, if you get a higher E2 level than what was expected according to the follicle number, then you can suspect that she might land up in OHSS. Okay, number of oocytes retrieved. So I've already mentioned that if there are more than 25 to 30 oocytes that have been retrieved or at pickup, then she's more likely to land up in OHSS. Then raised VEGF levels. This is not done routinely, VEGF and inhibin. This needs to be done only for research purposes in some centers for few patients. HCG administration for luteal phase support. Remember, with agonist trigger, the luteal phase is shortened. There is early luteolysis with GnRH, agonist trigger in ANTAC cycles. So in those patients, if they go for fresh embryo transfer due to some reason, then there is luteal phase insufficiency, and low dose of HCG injections are given for luteal phase support. That is around 1500 international units. So those patients, if they become pregnant and if they had a higher number of follicles, they are more likely to land up in OHSS. And pregnancy. So if she becomes pregnant following embryo transfer, she is more likely to release endogenous HCG, which will consequently lead on to late and continuation of OHSS. Okay. Now, what is the E2 cutoff? I've already told 5,000 to 6,000 picogram per ml. More than 11 medium to large size follicles and elevated levels of elevated levels of estradiol or more number of follicles on day 5 or day 6 of stimulation. Okay, this is just a simplified figure which shows you that these are the risk factors for having OHSS. So young age, low BMI, previous history of OHSS, elevated estradiol level in case you're doing in the the middle of the stimulation to see, and or on the day of trigger. Routinely we do a E2 level on the day of trigger morning. So PCOS history under 35, previous pregnancy with a history of OHSS. PCOS we all know. Twin pregnancy is a case of multiple gestation. We know endogenous HCG is a trigger for ovarian hyperstimulation, late ovarian hyperstimulation. So if it is a multiple gestation case, obviously the endogenous HCG levels will be high and low BMI. So these are two figures which they are go-to figures to understand this patient is likely to have a likelihood to have OHSS. Okay, then we'll move on to classification. Any other doubts you can put in the chat. Okay, number of follicles retrieved predicts. Okay, see, number of follicles, obviously, we have been discussing that, no? With more number of follicles, there are three reasons. I had shown you a slide on pathophysiology. I'll again show you that. Just a minute. This one. Okay, see, just give me a minute, please. 1 minute. EGF is one. Hello?
Yeah. Yeah, Dr. Lipika, your screen share is gone. Can you share the screen again?
Yes, sir. I think the internet connection was unstable. Just give me a minute.
Okay.
So is it visible now?
Yeah, perfectly fine. You can start now, Dr. Lipika.
Yeah. So I had already explained. See, your question was why does number of follicles predict ovarian hyperstimulation? So I think this figure is self-explanatory. With more number of follicles, what happens? You expect more exudation of fluid, protein-rich fluid. See, you have a bulky ovary with much more number of follicles than you had expected. So what happens is the ovarian surface is also scarred by peritoneum, where there can be an escape of fluid from the follicles into the third space. The ovaries are lying in the peritoneal cavity, right? So there is an exudation of fluid from the ovarian surface to the peritoneal cavity, that is same third space. So there is leakage of plenty of fluids and that causes hyperstimulation. That causes symptoms of OHSS. The second is there is the follicular fluid where the oocyte is growing, that is also rich in renin, prorenin. These are all inflammatory markers and they contract blood vessels to cause leakage of fluid to the third space. There is also angiotensin which causes inflammatory markers to be released and increase capillary permeability of the blood vessels which causes leakage of fluids. And you are already aware of VEGF. So therefore, more the number of follicles, there is more exudation of fluid from the surface of ovaries through the follicles to the third space. There is more of renin, prorenin which causes leakage of fluid and more amount of angiotensin that causes leakage of fluid. So with more follicles, what happens? The E2 levels go, isn't it? So we estimate on an average that 200 to 250 picogram per ml, there is estradiol level with mature follicle. So with more number of follicles, you'll have more E2 and more chances of having OHSS. Is that clear now? I hope it's clear. You can still, if you still have doubts, you can ask me. Okay, we'll move on to classification of OHSS. So how do you classify OHSS? There are several classifications which have been proposed for OHSS. So one is with, like mild, moderate, severe, and critical. This is easy to remember, but it is practically, you have to apply this in clinical practice to understand it. So with mild OHSS, you just have abdominal bloating and some degree of abdominal pain because you still have bulky ovaries in the pelvis. right? So she will say that she's still having heaviness in the pelvis. That will predict, that will indicate that her ovaries are still bulky. So abdominal bloating and mild abdominal pain. The ovary size are around, the greatest diameter of the ovary is more than 8 centimeter. And routinely with patients where you predict ovarian hyperstimulation, please call them for a post pickup scan at 48 to 72 hours. Sometimes patients don't complain because their pain threshold is high, but you routinely do where you predicted a OHSS in a PCO patient, somebody who has severe PCOS, who has very high AMH, you have more oocytes recovered from her on retrieval, you had very high E2 levels as high as 10,000. Call those patients for a post pickup scan within 42 to 72, 48 to 72 hours of pickup, within 2 to 3 days. I obviously see the ovarian volume. The cutoff which I take at 72 hours is 40 cc. So just like you measure ovarian volume on baseline scans, try to measure the ovarian volume in the post pickup scan as well. And if it's more than 40 cc, you can think that her ovaries are still bloated. What I do for her is I give a single dose of antag, a loading dose of antag, or 1 vial or 2 vial, whatever I feel like depending on volume or depending on fluid in the pelvis. I give her a antag injection which will bring down the hyperstimulation. Moderate OHSS, she'll have moderate abdominal pain. But with peritoneal irritation, she'll also have nausea, vomiting, and there will be ultrasound evidence of ascites. So on ultrasound, you can see that all the dependent pouches in the abdomen, in the POD, the Morrison's pouch, everywhere, in the most dependent parts of the abdomen, there will be fluid, okay? And the ovarian size is still larger than that of mild OHSS. So here the cutoff is taken as 60 to 70. There is no well-defined cutoff. This is what I estimate in my clinical practice. Those cutoffs I'm telling you. The lengths which are given, that is the longest diameter of the ovary. So with mild OHSS, the longest diameter of the ovaries will be around, that will be within 8 centimeter. With mild to moderate, it will be 8 to 12. With severe OHSS, ovaries are huge, more than 12 centimeter. And with critical OHSS, you will not be able to assess the ovarian size because the patient will be in a bad condition. So this is a tabulated flow chart which shows mild, moderate, severe and critical OHSS. Remember, in critical and severe OHSS, the biochemical parameters will be significantly affected. There will be significant hemo concentration and the hematocrit will be very high, right? And renal compromise will be there. There will be oliguria, anuria, because the vascular compartment is compromised. She doesn't have intravascular volume, so renal perfusion reduces and therefore the urine output also comes down. So invariably for inpatient patients who are admitted, OHSS patients who are taken inpatient, they are admitted, you have to monitor an input-output chart because it's very important to monitor the urine output in those patients. Okay, so one type of classification is mild, moderate, severe and critical. The other type of classification, there is another type of classification, we'll move on to that also. Grade 1, grade 2. So mild OHSS is defined by grade 1 and grade 2 compared, like they consider clinical features here. So abdominal distension, discomfort is grade 1. With grade 1, if she has vomiting, nausea and ovarian size is more, that is grade 2. So mild is grade 1, grade 2. Moderate is grade 3 and grade 4, and severe OHSS is grade 4 and grade 5. So one type of classification is mild, moderate, severe and critical. The other type is grade 1, 2, 3, 4, 5. Grade 1 and 2 are considered under mild OHSS. Grade 3 is moderate OHSS and grade 4, grade 5 is severe OHSS. This is again a pictorial figure which will make understanding easy. So with mild, you have increased E2 and P4 values. Large ovaries, abdominal distension might be mild with mild OHSS. With moderate, there is significant abdominal distension, there is raised E2P4 and there is large ovaries. With severe, you have both raised E2P4, you have large ovaries, you have significant abdominal bloating, damaged hepatorenal function and thromboembolic phenomenon due to hemoconcentration. So the blood in these patients becomes thick because of leakage of fluid to the third space. This is again a tabulated form. I think I've put everything here. You can see the biochemical parameters are compromised only in the severe form. Like significantly, if you find compromise of biochemical parameters, it starts with moderate OHSS, but it goes up to severe OHSS. So what are that comes under investigation, I'll tell you, but never forget to do the renal function, liver function, the coagulation profile, a complete blood count, and a hematocrit, which is also included in complete blood count when you assess patients of OHSS. I always do a electrolyte level and a protein albumin level as well, because these patients have lot of protein leaked into the third space. So the blood compartment is hypoproteinemic. Lot of protein has leaked into the third space as well. Now, severe OHSS, the electrolyte imbalance is significant, and with critical OHSS, obviously, she requires intensive care. So how will she clinically present? So according to time of onset, so this is the third type of classification. Number one is mild, moderate, severe, critical. Number two is grade 1 and 2 under mild, grade 3 under moderate, and grade 4, 5 under severe. And the third type is early and late, which I have been telling you several times throughout the lecture. So early OHSS happens within 9 days after oocyte retrieval. So this is the type of OHSS which we are trying to find out with the routine post pickup scan. So I tried to do a post pickup scan for most of the patients where I had thought of OHS is happening, right? So within 48 hours to 72 hours after pickup, you can routinely do a post pickup scan because she is likely to have early OHSS. It happens within 9 days after oocyte retrieval. It correlates to ovarian response and exogenous HCG stimulation. Now, what is late OHSS? So remember, early is exogenous. It is related to the trigger that you have given prior to pickup. What is late OHSS? It is related to the endogenous HCG hormone, which is released in the body because of pregnancy. If she becomes pregnant following embryo transfer, the endogenous HCG levels rise to a significantly high level, and therefore she'll have late onset OHSS after 10 days of ovum pickup. Now, this is the pathophysiology. I think we have discussed this in details. So, early HCG happens due to exogenous HCG trigger, and late OHSS happens due to endogenous endogenous HCG in the female body. Now, this is an overstimulated follicle. There is I think one of you were asking this doubt. There is intra-ovarian RAS activation, renin, angiotensin, aldosterone system, that causes leakage of fluid and release of VEGF, vascular endothelial growth factor, that increases capillary permeability. This, I think, again, we have discussed in details. So one is VEGF, one is RAS, the renin, angiotensin, aldosterone system, which consequently together they cumulatively add on to activation of like the inflammatory markers and increased capillary permeability. So this is, you can see, early OHSS happening within 3 to 9 days of pickup. This is late OHSS, which happens after 10 days because of endogenous HCG due to pregnancy. So what is the prognosis of this syndrome? With mild and moderate cases, excellent prognosis. They will recover only on the outpatient basis with observation. What is in the severe cases, the morbidity is clinically significant and even life-threatening consequences can happen. Death from OHSS is largely due to hypovolemic shock. So you know the intravascular component will have fluid depletion. Fluid will become less. Therefore, the organ perfusion will become less. This type of shock is called hypovolemic shock. Electrolyte imbalance can happen because of third space fluid leakage. Hemorrhage can happen because of hemoconcentration. Thromboembolism can cause organ perfusion reduction, and that can lead to multi-organ dysfunction syndrome. So even death can happen in 2 serious cases. Now, what are the management principles? So there are 3 P's: prediction, prevention, and post-OHSS. So prediction, we have discussed in details. Which patients are likely to develop OHSS, you have to predict depending on primary and secondary markers. Prevention, once you see early OHSS onset, you have to prevent the serious consequences. And once she has landed in moderate to severe OHSS, you have to do post-OHSS management. Now, prevention, I think we have discussed. Complete prevention is obviously not possible because most of the cases still remain unpredictable. However, it is of 2 types. So primary is to classify patients. Which patients can hyper-respond to stimulation? That is primary prevention. And secondary prevention is they are used once the risk factor is present. If you think this patient might land up in
Lipika, your voice is not clear.
those patients have to be kept under your OHSS. Is it clear now, sir?
Yeah, much better, much better.
Yeah. So what is the primary prevention of OHSS? You reduce, I've told you the triad of OHSS. One is overstimulation, one is over response, and one is HCG, right? So overstimulation can be very well predicted depending on the age, BMI, antral follicle, AMH. Okay. So if you find BMI is less, she's a lean patient, you had to start with 225. Please start with 150. Start with a lower dose. You can increase the dose later on subsequent scans. Okay. So reducing exposure to gonadotropin is the first step to prevent OHSS. Using combined OC pills, if you find she has a lot of follicles, you can down regulate her in the previous cycle where before you start stimulation. GnRH antagonist protocols are much safer to prevent OHSS. Avoid HCG as trigger and for luteal phase support. Even avoid HCG as trigger for patients who are expected to hyper-respond, especially patients with PCOS. In vitro maturation, you can do a oocyte retrieval at a smaller size of follicles, pick up the immature oocytes and later on do IVM for them, in vitro maturation. But this is not a very successful procedure. I think sir will agree. And insulin sensitizing agents. Metformin is commonly used for patients with PCOS, and that also helps in primary prevention of OHSS in patients of PCOS. Now, what are the other methods? I think I discussed the methods. We'll just go through the details. Now, reducing the dose, you can all understand this. You go for chronic low dose step-up protocol for PCO patients. We usually do not do this in clinical practice. You just start with a lower dose. If you wanted to start with 150, start with a lower dose. If you wanted to start the patient on stimulation with 225, start with 150 for 3-4 days. Scan her. If you see an expected response, continue with 150. If you get a lesser response, please escalate the dose to 225. Reducing the duration of exposure. So more the number of days of stimulation, more chance of landing up in OHSS. So that is how you reduce exposure to gonadotropin. Combined OC pills or leuprolide, GnRH agonist, you can use in the previous cycle from day 21 so that the ovaries are somewhat down-regulated before you start stimulation in a patient where you expect OHSS to happen, or go with lesser amount of dose. You start with low dose and then gradually escalate the dose. Do not start with a very high dose. There is a step down protocol as well where some patients are started on a very high dose and then the dose is reduced. That also prevents OHSS. Antagonist protocols, we are all aware that antagonist cycles are very common these days and they obviously have a lower incidence of OHSS with antagonist cycle. What are the other advantages of using antags? There is lack of flare effect. So we know GnRH analogs are of two types. One is agonist, one is antagonist. With agonist, you have a short flare period. So that stimulates the ovary for some days. There you can land up with OHSS. There is more incidence of OHSS with agonist compared to antagonist. There is no accompanying menopausal symptoms with antagonist. With agonist, there is suppression of endogenous estradiol. So the patient has menopausal symptoms, but with antagonist, it's not there. Antagonists act immediately. With agonist, there is a refractory period where there is flare and then the agonist act. But with antagonist, there is immediate effect without any refractory period. There is reduced chances of ovarian cyst formation. There is a shorter treatment cycle. So for prevention of OHSS in expected patients, what we want is a shorter exposure to gonadotropin. With antagonist cycles, the cycles are short and there is less amount of FSH consumption with antagonist cycle compared to that with agonist cycle. So this is again very, very important. I've already mentioned that in cases where we use agonist trigger, but we have to go for fresh embryo transfer, you need a luteal phase support because there is early luteolysis with GnRH agonist trigger. There is an entire talk on luteal phase support, which Madam will be taking, and this will be discussed in details. But there are some clinicians who go for HCG very low dose, like 1500 units, international units for luteal phase support 3 to 5 days after pickup. So that can again increase exogenous HCG and consequently land up in early or late OHSS. So therefore, HCG should not be used. You can use other drugs like progesterone and all for luteal phase support if in case you require early like fresh transfer, but do not use HCG. This is the culprit. IVM, I've told you, you pick up the oocytes earlier and mature them in the lab, but this is not a very successful strategy. There is a different IVM media where the oocyte needs to be grown to mature it, to come to M2 phase. Then there are insulin sensitizing agents like metformin, which can be used. And for patients with PCO who have a higher chance of having OHSS, you can give metformin because most of my patients on PCOS, when they are undergoing IVF stimulation, they are already on metformin, and metformin has been documented thoroughly to reduce the incidence of OHSS as well, apart from the multiple other advantages it has on oocyte quality and glycemic control. So don't forget to keep your patient on metformin while she is undergoing stimulation for ICSI. IVFXC. Okay. Now, what are the secondary prevention? So, what we have discussed is primary prevention. When you find that a patient is likely to develop OHSS and you have taken preventive strategies, that is primary OHS, primary prevention. When you find that there is risk factor and she has symptoms of OHSS, that is where you need to take secondary prevention strategies. So this is a list of drugs list of methods which are used for secondary prevention. I'll quickly go through each of it. Okay, so what is coasting? It is withholding further gonads. So you see a very hyperstimulated ovaries with much more number of follicles than you were expecting on that day. Then stop gonadotrophin stimulation for 1-2 days and delay HCG administration for triggering before pickup. So, but one important point to note is that coasting cannot be continued beyond 2 to 3 days. So you have started stimulations. Yes, she has spent so much. You cannot delay gonadotrophin injections and the trigger injection beyond 2 to 3 days. So, but the evidence of coasting to, like strongly favor coasting is not very strong, but it is a clinical practice wherein we stop gonadotrophin stimulation and HCG triggering, or we delay it by 1 to 2 days. Now, reduced dose of HCG, this is obvious. In all of the antac cycles, we often go for agonist triggers, but in case you're going for HCG triggers, please give a lower dose. Don't think of 10,000 or 2 vials of recombinant HCG 250 microgram. Give 1 or give 5,000. Or another option is giving a dual trigger. I'll take a topic on trigger. There is an entire detailed topic on trigger on 30th. So we'll discuss all types of triggers that are available and what you can do to reduce OHSS will be again taken up there. Then cryopreservation of embryos. So what I've already discussed is that with fresh transfers, and if the lady becomes pregnant, there is increased release of endogenous HCG. So that will land up in late OHSS, and the OHSS symptoms will continue for a longer time. So what we can do for preventing OHSS in a patient where it is likely is that you can always just you can do is you can delay the embryo transfer, you can freeze the embryos, you can do the embryo transfer in the next cycle, and we just have to prevent her from getting pregnant. So no fresh transfers, cryopreserve all the embryos, go for transfer in the next cycle. So number 1 is coasting, number 2 is reduced dose of HCG, number 3 is cryopreservation of all embryos and consequent transfer in a subsequent cycle. Cycle cancellation is cancellation and withholding of HCG is probably the only guaranteed method for prevention of early OHSS. But this is rarely done. I've never done cancellation of cycle because of OHSS prediction, because she has spent a lot and you are on the verge of finishing the cycle. Why do you cancel the cycle there on the trigger day? Okay, so you do the pickup, you take all possible measures to prevent OHSS. I'll read out all medications. Now, there are very common medications which are easily available and very important steps you can do post pickup to prevent OHSS. Now, what are the alternate agents for triggering ovulation? I've told you agonist, which is a very, very common option, decapeptyl, triptorelin, that is available. This is an agonist trigger and it's a very, very safe method. The only thing is that you cannot go for fresh transfer if you have given an agonist trigger because of luteal phase insufficiency. Okay. The next method is recombinant LH. So what is the endogenous hormone which naturally triggers ovulation? It is obviously LH. With LH surge ovulation happens. So why not recombinant LH for giving trigger? Isn't it? Only because it is very, very costly. So if you need a trigger amount of LH corresponding with 5,000 units of HCG, the cost of trigger will be around 50-60,000, which is very costly just for triggering the cycle. Therefore, this is not practically used. GnRH antac salvage, this is very, very commonly done. So post pickup, where I expect a patient to land up in early OHSS, I give an antagonist injection, 1 injection twice daily for 3 days post pickup. I then call her for a scan at 72 hours. I monitor the ovaries. I see for fluid in the POD, in the pouch of Douglas, and therefore I can safely send her home that there is no likelihood of you developing early OHSS, because late OHSS we don't do fresh transfers routinely. Then another measure is intravenous albumin and hydroxyethyl starch. So post pickup, if you feel that she can land up in OHSS, there were a lot of follicles, please give her a protein infusion. Okay, with intravascular volume depletion, lot of protein is lost into the extracellular space. So if you give protein into the blood vessel, what happens? Protein increases the oncotic pressure in the vascular compartment, and that will draw the fluid from the extravascular space to the the intravascular component. Okay, so that is how you reduce the onset of early OHSS. Another measure is hydroxyethyl starch. HES is available. It is just like a saline infusion, 6% hydroxyethyl starch that is also given to increase the oncotic pressure or increase the osmolarity of the fluid in the intravascular component. That will draw the fluid from this third space within the to the blood vessels. So the edema in the third space reduces. You've commonly heard of dopamine agonist, that is cabergoline, which is commonly given. So I start cabergoline on the day of trigger. I start 0.5 once daily for 7 days. So that covers the entire period where early OHSS was likely. Okay, calcium gluconate infusion. This is again given to increase the osmolarity of the intravascular component. How is it given? 10 ml. It comes in a injection form. So just give 10 ml of 10% calcium gluconate injection in 200 ml of physiological saline within 30 minutes of ovum pickup. After pickup, just start it in the OT or on the day 1 or day 2 post pickup. That can also be as helpful as giving cabergoline. Another method is starting steroids. So you will all agree that steroids are anti-inflammatory, isn't it? So ovarian inflammation, ovarian hyperstimulation is also an inflammation. So we need to give a low dose steroids or glucocorticoid injection or tablets, which will bring down the inflammatory markers and reduce the severity of possible early OHSS. So this is a tabulated form, all of which I have discussed. You can take a picture of this slide if you want. This is the measure with the like the possibility and the likelihood and what is the evidence in favor of those measures. Okay. Now this I wanted to discuss, although these are not recommended in the guidelines given recently by ESHRE. However, these are very common methods which a clinician does. Now, what is follicular aspiration? Aspiration of granulosa cell from one ovary before pickup has been proposed as a measure of inducing intra-ovarian bleeding and limiting production of OHSS mediators from one ovary, and then you do pick up from the other ovary. So what happens when you see a lot of follicles in both the ovaries, you're not compromising much on the oocyte number. If there are 30 follicles in each ovary, what will happen if you just aspirate some follicles prior to the pickup and you just discard that follicular fluid? Don't be afraid, because you're going to get 30-40 oocytes, isn't it? So that is one method, because you're actually clearing of the granulosa cells which are mediators for OHSS. So that is one common method, although I have rarely done this 3-4 times, but this is a valid method. It's not given in any recommendation, but you can do pre-pickup follicular aspiration for few follicles in order to reduce the incidence of OHSS in patients where you actually expect OHSS to happen. Other two methods which I've come across lately, I've been using routinely for last 1 year with tremendous miraculous results. Okay, there is significantly improvement in symptoms of OHSS, early OHSS, if you use letrozole. Remember, this is one added benefit of letrozole. So letrozole as an aromatase inhibitor has n number of benefits apart from ovulation induction alone. One of it is prevention of OHSS. There are many papers. I have a talk recently, letrozole and prevention of OHSS, in one conference. So there are many papers. I'll share the papers with you. What is the recommended dose? We know that 2.5 milligram dosage of letrozole is available. So 7.5 milligram daily, once daily from the day of trigger for 10 days post pickup, you can absolutely reduce symptoms of OHSS. Now, how does this act? Okay. So we have already discussed in details extensively. Estradiol is a strong mediator of determining OHSS, and VEGF is again the most important culprit for OHSS. Now, what does letrozole do? We know it is an aromatase inhibitor. It is a competitive aromatase inhibitor. What does aromatase enzyme do? It converts androgens to estrogen. So if you're giving an aromatase inhibitor, the levels of E2 will come down. So obviously OHSS incidence will come down, and letrozole also reduces levels of VEGF significantly. Okay, so because it reduces E2 levels and it reduces VEGF, there is significant reduction of OHSS with 7.5 milligram letrozole once daily from the starting of trigger, from the day of trigger for 10 days from that. So 7.5 milligram from the starting of trigger for 10 days. Some clinicians give it for 7 days. That is beyond 3 to 4 days post pickup. I give it for 10 days. Another very good use of mifepristone. It is easily available, 200 milligram doses. 25 milligram mifepristone can be given once daily. So we know progesterone is a pregnancy supporting hormone, isn't it? So an anti-progesterone will like it will not support implantation. So mifepristone is an anti-progesterone, Ru486. So dosage available is 25 milligram OD. You can give it from the trigger day for a week till covering 3 to 4 days post pickup. So 25 milligram OD from the day of trigger for a week helps in reducing OHSS. My clinical experience with mifepristone is, I think, around 10-20 cases I've done, but with letrozole I've been using extensively for 1 year, and there is significant reduction of OHSS symptoms. Now, what is a cocktail regimen? This is something I came across while preparing for this lecture actually. So it is a combination of using an anti-protocol with agonist trigger, with letrozole and mifepristone. So this is a cocktail. Now, how does it help in prevention of OHSS? Enhance synergistic effect. So each of these methods is a OHSS prevention strategy. So when you combine all of them, there is enhanced cumulative effect for preventing OHSS. There is lower level of E2 and VEGF compared to individual methods alone. There is lower ovarian volume post pickup scans. There is short luteal phase. So you cannot go for fresh transfers with agonist triggers. This is a summary. These figures just simplify methods for OHSS prevention. Lowering hormonal dosage, GnRH antagonist, cycle cancellation is one method rarely done. Embryo cryopreservation is almost always done, apart from few cases where we go for fresh transfer, isn't it? So OHSS risk can be reduced by cryopreservation and by cancellation of the cycle before egg retrieval. Now, this is treatment. So you need to, I'll go quickly through this because this is, this has to be individualized, case based. Most of the cases are mild, so they can be handled on the outpatient basis. Only severe and critical cases need to be admitted. So history taking is very important, where you predict which patients are likely to have OHSS, physical examination for ascites, for pleural effusion, body vital signs, body weight, if the abdominal girth is increasing, so you understand that she is accumulating fluid in her abdomen. That is important. So outpatient management is just for mild to moderate cases, wherein you do a routine list of investigation, protein, albumin, hepatic and renal compromise in the function because of decreased vasoperfusion, and then inpatient method, input output charting has to be done. So this is again a tabulated form. These are the investigations which need to be done. You can take a picture of this. History and examination is again very important. However, if she is severe OHSS, paracentesis or tapping of the pleural peritoneal fluid needs to be done. We'll not go into details. Transvaginal guidance has to, like if you're tapping fluid from the POD, that is called cultocentesis, through the transvaginal guidance, that can be done. If she's not able to breathe, pleural fluid needs to be tapped, abdominal fluid needs to be tapped. But just remember one very, very important thing, because she's losing fluids from the blood vascular component, just don't give her fluids to drink. Too much of fluids is not going to help her, because that too much of fluid which you have given her by drinking or through fluid infusion, that's also going to escape into the extravascular compartment, because the pathophysiology is still increased vascular permeability. So just drink as much as she's thirsty. That is very important. And diuretics do not give. If you find renal parameters are compromised, still do not give a Lasix, do not give furosemide. Why? Because her intravascular component is already depleted. Renal function is already compromised, and that is why she's not having urination. So diuretics will further bring down the intravascular compartment fluid. Okay, then treat her symptom wise. If she's having nausea, vomiting, approach that. Anti-emetic agents should be, which are considered safe, need to be given. If after being pregnant and she's having late OHSS, which is very severe, please do not hesitate to terminate that pregnancy, because life is much more important. Otherwise, she can have fatal consequences. Okay. This is again a flow chart which shows where you need to do what, where you need to admit the patient. Remember, surgical treatment for OHSS is only required in case of ovarian hemorrhage, torsion of the enlarged ovaries. Despite all your conservative methods, if the ovaries are very bulky and they are twisted on the pedicle, then surgical intervention needs to be done. Rupture of the ovaries and ectopic pregnancy. So those pregnancies need to be terminated. Therefore, for late onset OHSS, please do a TVS to see both side tubes. Just don't have a look at the investigations which you have done, if renal function, and it is a multidisciplinary approach. If renal function is compromised, you need other clinicians to help you in your management of OHSS. A gynecologist cannot handle severe OHSS in the inpatient patient just by herself or himself. So you need a multidisciplinary team to approach severe and critical OHSS. These were the guidelines of preventing OHSS. And some things I always say happen out of clinical experiences. Not all guidelines will apply to your population or your set of patients. So do things out of your clinical experience. Clinicians must remain alert to the possibility of OHSS in all women undergoing fertility treatment, and women should be counseled accordingly. So if you see a young patient with high AMH, with the polycystic appearance of ovaries, with a low BMI, she is lean and thin, she is more likely of landing with OHSS. So please counsel her when you start stimulation. Start with a lower dose, increase the dose if you see adequate response hasn't happened with that lower dose. Fertility clinics should provide verbal and written information concerning OHSS. So, there is no OHSS free clinic universally. So please don't miss out on mentioning OHSS and taking a verbal and informed consent in a signed form that you have explained about OHSS, especially before you start stimulation and for patients where you feel that OHSS might happen. Yes, I think this is all. I think I've covered everything. Just remember, don't give non-steroidal anti-inflammatory drugs for these patients because they already have a compromised renal function. So because of pain, you give NSAIDs, isn't it? Just for anti-inflammatory, for analgesic and anti-inflammation, you give NSAIDs. So don't give NSAIDs to this group of patients with OHSS because their renal function is compromised, and this group of drug is excreted via the kidneys. So you're putting more stress on the kidneys. Remember 2-3 important things. Don't give her too much fluid to drink because that will again lead to the extravascular space and increase OHSS. And don't give painkillers in the form of NSAIDs. And don't forget to give thromboprophylaxis because she is likely to develop thromboembolism. So give antiplatelet drugs in sufficient amounts because she needs low molecular weight heparin for thromboprophylaxis, especially if her coagulation profile and her platelet count is disordered on the CBC panel. So don't forget to give an anticoagulant. Hospital admission, yes. I've told you severe and critical OHSS patients where you cannot manage in the outpatient basis, please admit them into an inpatient department and they need ICU care and you need a multidisciplinary team to monitor and supervise their management. So again, I've written here, fluid replacement should be guided by thirst. If she's thirsty, give only that much fluid. Otherwise, you're worsening symptoms of OHSS. So what are the recommended treatment for OHSS? It is metformin co-treatment for PCO patients, lower starting dose of FSH, gonadotropin antagonist protocol with agonist trigger, avoid HCG for trigger and for luteal support, dopamine agonist, elective single embryo transfer, that too in a subsequent cycle, and freeze all is preferred. What is not recommended is mifepristone, letrozole. All of these are absolutely not recommended, but in clinical practice, they work wonders. So do not forget to add these drugs to your prescription where you suspect a OHSS to happen. This is a very good flow chart which shows you what are the interventions with the dose. So you can take a picture of this slide again. So freeze all, but it need not be universal. So still always keep predicting, have an eye, be supervision, you have to be observant for early OHSS feature. Just because you didn't go for embryo transfer doesn't mean the patient will not have early OHSS. So please do a post pickup scan 48 to 72 hours where you suspect that early OHSS can happen. So this is a summary flowchart: ovarian hyperstimulation, release of vasoactive substances, increased vascular permeability, fluid accumulation in third space, hypovolemia. This is what happens in OHSS, and this you have to understand to manage the cases well in your OPD. Okay, and these are the management strategies, very, very important. So VEGF is always the most important culprit. E2 is again a culprit. HCG is a culprit, but there are inflammatory cytokine markers which are also very significant in the pathophysiology of OHSS. So this is a simple table which tells you what are the measures you can take for OHSS prevention, both primary and secondary, and the red and green part is the most important, which is in your hands. You can do that. This is a summary of the preventive strategies for OHSS. Okay.
Can everyone hear Dr. Lipika? Can somebody just tell? Because Dr. Iguilo is saying she can't hear you, but her voice is clear to me.
So are you able to
Yeah,
hear,
yeah,
sir?
absolutely. Very nice, clear, nice and clear.
Okay, maybe the internet connection with her is unstable
Maybe.
because I think I'm quite loud, sir.
Yeah, yeah, it's clear. Yeah,
Okay.
yeah.
So this is again a summary of the preventive strategy for OHSS. Please have a picture of this. There are some take-home messages, One is fluid maintenance. So have a look at her fluid. Do a post-pickup scan. Start with a low dose of gonadotrophins. Post-pickup, start with an albumin infusion or a hydroxyethyl starch. Please go for calcium gluconate injection. Start with letrozole or mifepristone for on the day of trigger if you suspect, and a dopamine agonist as well. So these are some important 5-10 points which you have to remember regarding OHSS. Just remember, we are lucky that we have major cases as mild OHSS, which are managed on outpatient basis, but still don't leave her that day. Just keep an eye on her, wait for her blood reports to come, monitor her well, keep her under your supervision before you leave her home. Okay, and moderate to severe and critical cases need to be like admitted. Okay, so anyone who stops learning is old, whether at 20 or at 80. Anyone who keeps learning stays young. Even for this talk, I learned 2-3 new points. So keep learning. Let's help each other to learn. I'll learn more with your doubts. OHSS is considered as a failure of IVF ART procedures. Therefore, an OHSS ART free clinics should be the norm today. So we'll all target to make our clinics OHSS free, but OHSS free clinics are not a reality universally. So we still have to be vigilant with the number of PCOS cases increasing, rampantly. Any other patient you look at is a PCO patient. So how can you be OHSS free? You cannot be free of OHSS in your mind if you're an IVF consultant. It is absolutely a nightmare. It will not let you sleep after the pickup. So be very vigilant and use preventive strategy before she becomes serious. Any questions? I'll be happy to take.
Dr. Lipika, wonderful lecture as always, and beautiful slides. Amazing
Thank you, sir.
representation. Very nice. Even I have taken a lot of screenshots today. Wonderful presentation. Any
Thank you,
questions?
sir.
I'll just see the chat box. Can we use
Yes,
bromocriptine?
very good question. That was a very good question. I expected someone to ask. So just remember, there are two common categories of, dopamine agonists, which are used in clinical practice. Number one is cabergoline. Number two is bromocriptine. So just remember 2-3 important points of difference between the two groups of drugs so that you yourself can see. So bromocriptine has a short half-life. So when you're going for fertility treatment in ovulation induction cycles, in many patients with PCOS, you see a thin endometrium on day 9. So that is where you suspect that she could be a patient with hyperprolactinemia, and you can add bromocriptine to your estrogen. If you're giving estradiol to increase the thickness of the endometrium, you can give bromocriptine as well. But bromocriptine has a short half-life. It doesn't stay in the body. So for hyperstimulation, what do you need? You need a dopamine agonist which will stay in the body for some time, and that will reduce the levels of VGF, isn't it? And that will also reduce the effect of FSH on follicles. So cabergoline has two mechanisms of action. It reduces the effect of FSH on the follicular growth, and it brings down VEGF levels. So that reduces the hyperstimulation. So for prevention of hyperstimulation, please choose cabergoline over bromocriptine. But for normal ovulation induction cycle, for infertility treatment, for hyperprolactinemia and infertility in PCOS, go for bromocriptine. What is the dose? It is 2.5 milligram per day for 10 days bromocriptine. For cabergoline in OHSS, the dose is 0.5 milligram daily for 7 days from the day of trigger. And cabergoline has 1-2 more side effects. I've seen hypotension happening with cabergoline. So whenever the patient is taking cabergoline, ask her to take in sitting position with a plenty of water. Right? We don't understand why she's having reeling of head. It could be because of intravascular perfusion reduction also, because fluid is leaking into the third space. So just think that it could be because of cabergoline as well. So ask her to take cabergoline in sitting position with a plenty of water so that the hypoperfusion to the brain reduces.
Yeah, that's a very valuable input, Dr. Lipika. Some people are asking for recording, slides, etc. So this will be uploaded on the YouTube as well as on the app. So don't bother. Just wait for one day. By tomorrow evening, you will have the slides and the recording. Everything will be available on YouTube.
So I think there are two, three more questions. One is GnRH antagonist salvage. Very, very important question. Very valid. I think I've told everything, but it could have been missed with the extensive session. So I'll just tell you again. Please remember antagonist. Although antagonist protocols in the controlled ovarian stimulation, that is a safer protocol for preventing OHSS. Please remember antagonist can be used as post pickup in patients where you expect OHSS to have 0.25 international units subcutaneously. You have vials of antagonists. So what I do is significant amount. All right, that is one protocol. Second is that if you have severe, suppose I had a patient where I had retrieved 80 oocytes, loading dose of 3 vials BD for 3 days. So you can use individualized protocols. And one more option is that when you call her routinely for a post pickup scan after 48 to 7 on that day and you send her back. Okay, that all right. So one is mild, moderate, severe, and critical. One is grade 1 to grade 5. So grade 3 is moderate, and grade 4 and 5 is severe. So basically, the clinical symptoms are the only. So one is mild, moderate, severe, critical. One is grade 1 to grade 5, and one is early and late OHSS. Triptorelin is available. So you can give either one vial widely for you. Any other questions? Cabergoline dose is 0.5 milligram once daily from the day of trigger for 7 days. Some clinicians also give it for 10 days. So, you know, that covers the oocyte retrieval day and 3 to 4 days following that. Okay. So I think we'll wind up. Please note down your questions. We have again extensive sessions when we go for the, see, best method is always a cocktail regime. So like GnRH antagonist cycle, GnRH agonist trigger, followed by letrozole, addition of letrozole, dopamine agonist. That is all. See, this is all, you know, your individualized case-wise approach. So if you ask me for a patient where OHSS is very likely, I would give her an antagonist cycle with agonist trigger, with dopamine agonist and letrozole. That is what I'll do. And immediately after pickup, I'll give her antag. That much is enough. For patients where very severe OHSS is likely, I can give a calcium gluconate infusion or an albumin infusion from outside, 1 bottle of albumin. Letrozole dose is 7.5 milligram. So it is usually available in tablets of 2.5 milligram. You can give three tablets. 3 tablets OD from the trigger day for 10 days. So that will again cover the retrieval day and 7 days following that.
Dr. Lipika, very nice session and good healthy discussion also. So in the end, I would just like to reiterate that the last date to join the course is 25th of this month, May, and we start on 28th of May. And after a couple of days, you will be having another demo session on embryo grading, which I'll take up on 23rd, that is Friday. So you have a few more days to, register for this wonderful course. Kindly do that at the earliest because after 25th, the fee will be hiked. There will be still 2 more days to register, but then the fee will be more. So it's good to register in time and attend the sessions. The sessions will be wonderful and everything will be taken up. If you have any more queries, you can put in the demo group which you are part of, and we'll be happy to answer. Thank you so much.
Thank you so much, everyone. So I think we can wind up.
Yeah. So I'm ending the meeting, Dr. Lipika.
Yes, thank you.
Thank you. Thank you. Good.